Good morning, everyone. I'm Dr. Tara Kieran. I'm a family doctor at St. Michael's Hospital and also the Vice Chair for Quality and Innovation at the Department of Family and Community Medicine at the University of Toronto. I'm really pleased that our department is able to collaborate with the Ontario College of Family Physicians to host these COVID community of practice sessions where family physicians come together to talk about how we can support each other during COVID. I'm going to turn it over to Jennifer Young to provide a short introduction.
Thanks, Tara, and it's great to join everybody for this 7th session. It's a wonderful collaboration, and the stuff we've shared over the last 6 sessions has been really great. And the information that's been shared on those is on our website and on your website, so we can you can still gain insights from what our colleagues have shared over the last few months. We hope all's going well. We welcome today Alan Kaplan and Jonathan Bertram and to talk about managing chronic conditions. But before we get started, I'd like to begin with a land acknowledgement, where we acknowledge that the land on which we're hosting this meeting is the traditional territory of many nations. We acknowledge that Ontario is home to many diverse First Nations, Inuit, and Métis people, and that each of you are joining us from one of those many traditional and treaty territories. We are grateful to be able to come together in this way.
I always find the land acknowledgement an important time to reflect on injustices done to Indigenous people in the past and continuing in the present. And today I just wanted to share a blog written by one of my own colleagues at St. Michael's Hospital, a family doctor and mother of 3 who identifies as both Indigenous and of Black ancestry. And I think she wrote this really powerful blog that calls out some of the injustices, particularly the high rates of violence that are experienced by Black and Indigenous people, and the high rates of incarceration. Now, I think while her solution may feel controversial, I still urge you to just read the blog, because I do think her perspective is one that was passionate and really well articulated. So if you have a chance, that link is on the chat. Today, of course, we're coming together to talk about managing chronic conditions, something that's on all of our minds. And we've always kind of placed ourselves with this community of practice as a place where we don't necessarily have all the answers. This is a time where we're having to develop the answers together and learn from one another. And in that spirit, I look forward to learning from our panelists today and from you. As Jennifer mentioned, we've included the link to where the webinars and related resources will be posted afterwards. I just want to give a shout out to our planning committee. Our planning committee is the one who selects the speakers and designs these sessions. And so our panelists today, Alan Kaplan and Jonathan Bertram. And in addition, I'm going to be sharing some perspectives myself. We also, of course, are delighted to be joined as usual by Dr. Jennifer Young and Dr. David Kaplan, who both have provincial leadership roles and can often provide a really important perspective. So without further ado, I'm going to turn it over to our panelists to introduce themselves and speak to their disclosures. Alan, do you want to go first?
Thanks, Tara, and welcome everyone. My name is Alan Kaplan. I'm a family physician from the north part of Toronto in York Region, where now masks wearing in public is mandatory as well as everywhere else. I'm involved with a lot of different companies, as you can see up there. I'm the chair of the Family Physician Airways Group of Canada, and the past chair of the College of Family Physicians Respiratory Medicine section. So I'll be talking about chronic management of respiratory conditions, particularly asthma, COPD.
Hi, everybody. My name's Jonathan Bertram. I'm a focused practice family physician, and I work at 2 sites in Toronto at the Center for Addiction and Mental Health, in addictions medicine, and out in Bowmanville, just east of Oshawa, in a community clinic focusing on pain and addiction. And I have nothing to disclose.
Thanks. And so I'm lucky to be supported as a researcher, and so I do have a few grants that I've listed there. All of the grants and salary support I receive are from nonprofit agencies, with the exception of a grant from Gilead Sciences that was to support a project to cure Hep C in primary care. David?
Hi, I'm David Kaplan. I'm a family doctor in North York. I'm the provincial chief of clinical quality at the new agency, Ontario Quality, in the quality branch. I'm also at the North York Family Health team. And I look forward to being able to contribute this morning. So thank you very much for having me. And to all of our colleagues out there on the webinar, you can now see that Alan Kaplan and I are two totally different physicians. Sometimes Alan gets my mail, sometimes I get his mail, but we are not the same person. So it was nice to see us both in two different webinar slides.
And there's no nepotism, we're actually not related. Okay?
And we're not related, exactly.
And hi, everybody. I'm Jennifer Young, a community family physician in Collingwood, Ontario. I'm the president of the Ontario College of Family Physicians, and I have no relationships with industry to disclose.
So, of course, this webinar is also about you, and it's wonderful to have so many attendees from all across Ontario. So this, I think, visual just does it all. Of course, there's lots here in the GTA, but also much further onward from Ottawa and smaller communities. I just wanted to go over with people how to participate today. So if you have questions for the panelists, please put them into the Q&A. Our panelists will either answer them live or they'll type the answer in for you. If you have resources you want to share with others, please put them into the chat. So only panelists can answer the questions in the Q&A, but if you have resources or answers you want to share, just put them into the chat. And then at the end of the webinar, we do try and compile all the resources that have been shared and send them out to the participants, both in an email and posted on our website. So without further ado, I'm going to turn it over to Dr. Kaplan, and who's going to talk a little bit. I guess, Alan, you've spent a lot of time. You have a very broad practice, I think, and some of it, I think, really focuses on how can we best manage chronic lung conditions like COPD and asthma. And so I think a lot of us would love to hear more from you on those topics. I know you actually published a fantastic blog on Canadian Family Physicians that many of us have read. So what are some of your tips for how to manage COPD and asthma during COVID-19, given sort of the risks and balances that all of us, the risks and benefits that we have to balance now with in-person and virtual visits?
Thanks, Tara. So I think we have a lot of opportunities here with the advent of virtual care that we're now actually getting compensated for to actually do a good job at looking after our patients with both asthma and COPD. A little bit of reference for where my recommendations will come from comes from physician statements from both the CTS as well as some physician statements from Gold and Gina, but I'll just use the Canadian ones. And the Canadian Thoracic Society has one on COPD, which you can see here, which basically the recommendations are take care of all the social distancing and stay home. Main point is, you have to treat exacerbations as you normally would. There's a lot of fear of steroids out there, which we'll talk about. The important message for both asthma and COPD is keep taking your medication. And unfortunately, a lot of people become afraid of taking medications like steroids or afraid it's going to make their COVID worse. There's some misconceptions out there. And the reality is that good control of all your conditions, I think you'll hear the same thing from Jonathan and Tara, that the bottom line is controlling your medical condition well is the best thing to prevent having severe COVID illness. In terms of COPD, the risk of getting COVID is not any higher, but the risk of getting severe illness is higher because you have compromised lung function, and therefore if you were to get ill with a bad virus, you're more likely to have a severe exacerbation requiring hospitalization and intubation. So there is certainly a higher risk in people with COPD for getting severe illness. A couple of particular things about respiratory illness is we do not want to use aerosol generating procedures. So nebulizers are not a really great idea. And the recommendation is that they should not be used. They're certainly not being used in acute care settings right now. People on home nebulizers, I suggest, shouldn't be used very much anyhow. They're not much value. But if you live with somebody else, you shouldn't be using a nebulizer. If you live on your own, it probably wouldn't matter. That being said, you should use your oxygen, even though that potentially, can spread things a little bit, but you need your oxygen. Oxygen is the only thing in COPD that keeps people alive longer. And one of the biggest issues for both asthma and COPD is the fact that we're not doing routine spirometry anymore. So actually measurement of condition, making a firm diagnosis is a little harder right now in the absence of being able to do spirometry. Now, there's a few ways around that, which we'll have a chance to talk about in a little bit. So the next slide really talks about how you measure somebody with COPD. And I'm not sure how many of you are familiar with the COPD assessment test. And the reason I'm showing just these couple of tools, and I'll show a couple of them, is in this new virtual world, I think we have an opportunity to send these kind of questionnaires to our patients ahead of our virtual visits, and therefore get an idea of how they're doing. And there's a number of tools we'll talk about during this program, but the COPD assessment test is a test of 8 questions, a Likert score from 0 to 5. 4 is about symptoms and 4 is about sort of quality of life, as you can see there. It started off as 180 questions. It got down to these 8 questions. And if you ask these 8 questions and also ask about exacerbations, you've got a pretty good overview of how someone's doing with their COPD. And you get the idea of the questions about symptoms in the first 4, but the last 4 are really important in terms of confidence, limitation of activity, sleeping, and energy. Really gives an idea of how they're doing psychologically and globally rather than just their lung symptoms. So if you're not using a COPD assessment test for your management of COPD, I suggest you include it. I'm not sure Jonathan's going to talk about brief pain inventory and so on for pain management, but there's also a measurement thing that we do for patients management. And I think we should include this in our management. So we can send this to the patient ahead of the visit. Next slide, please, Brian. I'm going to jump into asthma, and here's a CTS position statement on asthma. And the reality here is very similar messages. There's no increased risk of getting COVID in asthmatics. And interestingly, there's actually not an increased risk of increased severe COVID. So COVID, as you know, 85%, 90% of patients have mild to asymptomatic condition, with another 10 to 15% have more severe disease and 5% getting admitted to hospital. So asthmatics are actually not well represented in the data for severe COVID, which was surprising to us. And there's actually some opportunity potentially that ICS may actually be protective for viral replication. So maybe that being on medication is actually protective. But again, the most important message is use your treatment. Don't stop your biologics if you're on them. Biologics for asthma are not affecting the immune system. If you're on prednisone, keep using it. And the Society of Endocrinology has talked about the fact that people stop their prednisone acutely, they can get adrenal crises. So if you're on steroids, don't just suddenly stop them, although this might be a nice opportunity to think, can you start withdrawing it? But most importantly, continue using your inhaled steroids products to keep your asthma control, because the major message, of course, is keep good control to prevent having bad outcomes, because your asthma is not controlled, you're more likely to get in trouble with any viral infection. Next slide, please. So the tool for asthma control, there's many of them, whether we use the ACT, the ACQ, or just a simple 30-second asthma test, which is a very old one, which you're all familiar with those questions. If you want to be lazy and go with the RCP3 questions, which is even easier, it's just, have you had difficulty sleeping? Have you had any symptoms during the day? And has it interfered with your activities? So the point here is, don't just ask, are you okay? Get some kind of measurement of control, because you want to make sure that people are being managed appropriately and aggressively. So you're looking at control for asthma, you're looking at how they're doing in COPD, and you're looking at exacerbations. And the management of exacerbations is the same as you would otherwise, with the wrinkle in that equation being, how do you tell whether or not it's COVID? And if someone has respiratory symptoms, you're always concerned that this could be COVID. And very quickly, if someone is unwell, you're making a decision as a clinician, is this a COVID illness? And of course, you can have asymptomatic COVID, which makes it almost impossible to rule out COVID. But the reality is, if someone has fever and chills and aches, they've got an infectious illness and an issue. Whereas if they've just got a wheeze and it's responsive to their Ventolin, then probably it's probably not going to be the COVID that's inducing it. So next slide, please. I think this is a really nice opportunity to talk about smoking. And I think with smoking and people stuck at home, there's 2 issues there. Number one is, of course, that people are going to be bored and therefore they may smoke more. But the other opportunity is they're also not at work and not stressed. And if you speak to your smokers, many of them actually smoke at work because that's the only time they can get a break. So if they don't have a break and go for smoke, they actually don't end up having some release. So this is a nice opportunity because they don't need a work break, and perhaps this is an opportunity of getting something positive done during the pandemic that they can actually quit smoking. I remember we talked about the 5 A's, but I'm here talking about 2 A's, ask and act, so it's worth a conversation. And of course, we have all kinds of options for pharmacotherapy, which we can certainly talk about during the question and answer period. So I think I'll sort of stop there. Thanks so much, Alan.
There's already, so is that you getting paged?
Yeah, I'll shut it off in a second, sorry.
No worries. I just want, there are actually a ton of questions that are already popping in for you. Some of which I'm going to maybe suggest that we can try and answer live right now, and then some of which may ask you, Alan, if you can type some answers into the Q&A, because panelists, the participants have quite a lot of great questions. So just also for those who missed it, David Kaplan did post on the chat box a link to an OCEAN tool that allows you to send a pre-visit questionnaire for the COPD assessment test. So OCEAN, as we know, I think many of us are trying to do kind of as much as we can before the visit to make sure the visit is nice and short, and using pre-visit questionnaires is a great way to do that. Alan, there's a question about how are you supporting patients who insist that nebulizers are the only thing that work?
Well, the reality is the data is very clear. We learned this with SARS. So I was the vice chief of our emergency department when SARS occurred many years ago. We were the second hospital to get SARS. And of course, we had to understand then you couldn't use vaporizers. SARS was much more of an aerosol generating illness even than COVID. And we had to stop using them, bottom line. And the data is very clear, both adults and pediatrics, that an MDI with a chamber is just as efficacious as a nebulizer. So there's just really no indication for using nebulizers anymore. And acute care, most hospitals have actually moved away from nebulizers and moved to MDIs with chambers. So that takes away the infection risk from that as well. And efficacy-wise, it's okay. The difference is that when you use a nebulizer, you're using a lot higher dose, but 80% of the dose goes into the air and only 20% goes into the person. So with an MDI, you can take more puffs and actually get a really effective dose to treat an acute exacerbation.
So I think a couple of people have asked, you spoke about, they have patients with asthma requesting letters for work because they're high risk. But then I think you made that point that they're not actually high risk. So does this mean they're not at higher risk of severe complications from mild to moderate asthma? What suggestions would you provide to family doctors who are getting those requests for letters?
So the data, thanks, Tara. The data shows actually that asthmatics were not very well represented as a common group in people with severe illness. And that's the data from China, from Italy, and even from the United States. So asthmatics really are not a common group. COPD is different. They're a much more common group in intubated patients. And I'm sure you'll get into, Tara, in your presentation, diabetics, cardiovascular disease are very high. So asthmatics are really not high risk for severe disease. The thing that's going to prevent asthmatics from getting really sick is being well controlled with their asthma. So encourage them to take their medications. Now, should they miss work because of this? I don't think there's any validity to that issue. So I personally have not written any letters for asthmatics who want to be off work because of their asthma. I think that's not, now their anxiety is something else, but their asthma is not a reason for them to be off work. And the one other quick message I'll talk about is masks, because we have that as a big issue. And I see lots of people talking about the fact they've got a chronic illness and their asthma is a concern for wearing their mask. And they've actually done studies looking at CO2 levels and looking at carbon dioxide retention, and it doesn't happen with the conventional regular masks that we wear. It might happen with an N95. So you can wear a mask. If you're having problems with your breathing with your mask, it's probably anxiety and not your breathing. And we have to teach people to gradually get used to their masks, and that's there. But I think I personally don't think people need to work off. To answer your question, Tara, I don't think people should be given notes off work for their asthma. COPD may be a little bit different. Depends on the severity of their COPD as well.
So I'm going to ask another question. I noticed that your video is going in and out of focus. I don't know if there's something you can do about that while I'm just getting the next question up here. There are a couple of people who are really talking, I guess, about this idea of who to examine in the office and how to handle that. So, Ruma Chowdhury asks, do you get all your COPD patients COVID tests done if they call saying their cough is kind of lingering this time, but they have no fever or shortness of breath? And then Rosemary Law, this is a bit of a different question. There's a fall cough and cold season. How do you suggest we manage things in that fall cough and cold season?
So each individual patient that you talk to, no matter what the condition, you have to make a decision whether or not you think they might have COVID before they ever enter the office. If someone has respiratory symptoms, by definition, they've already screened positive. So I know that in our hospital, I just admitted somebody to our psychiatry unit who ended up having a fire in their house. And of course, their COPD was worse because they were in a fire. And everyone got excited because they could have COVID because they were coughing. Well, they were coughing because they had COPD and they were in a fire. But nobody was happy until the COVID swab was done. So I think in this new world, it's not unreasonable for COVID swabs to be done if you have any doubt, especially because you can have asymptomatic disease and you never really know for sure. But again, I'll stand by what I said initially, which is if you have fever, chills, and aches, that's an acute COVID infection until proven otherwise, and that's a swab. If you've got other symptoms, Yes, you can have GI symptoms. If you have lack of smell, I suppose, acute lack of smell, that's another symptom. Those are all things that would make you do testing. The difficulty is, what are you going to do in your office? Well, a lot of these people are going to be seen virtually, and you're going to decide whether or not they have to be seen somewhere in person to get a COVID swab. You decide whether you're going to do swabs yourself in your office or send them to an assessment center. If you've got viral swabs and pertussis swabs in your office, you can actually do your own COVID swabs. Just recognize that, sorry about my camera, but I can't stop it, that recognize that if you're doing that, you're exposing your office to people with COVID. And I actually had that early on in my office. One of the doctors did a COVID swab, didn't tell anybody, was positive, and therefore I ended up on quarantine for a little while till my swab came back negative. So I'm doing it out of the office, doing it in their car, things like that to do with appropriate PPE to protect yourself and your staff is important. That wasn't the perfect answer to your question, Tara, because I don't think there is one. I think we have to clinically make a decision whether we think that person has COVID, take appropriate precautions for yourselves and your staff if you think they are. And for me, it's going to be COVID till proven otherwise, and proven is going to be either that it's impossible based on the story and their risk is really small. I mean, remember, if someone's a 70-year-old patient with COPD and they haven't left their house for the last 3 weeks and their family brings them food, it's pretty unlikely they're going to have COVID. Whereas if they work in a meatpacking unit and they're beside somebody this far away, then it's more likely. So we have to put all that into consideration. So it's not a perfect answer. I think it's a little bit of
Yeah, and actually David Kaplan also, I think, had some thoughts about this, and you put something in the Q&A, David, also related to this question, and I wonder if you could speak to that.
Sure, I can. So I think one of the things that is difficult in this period of time, until we know exactly what the different provincial resources are going to look like as we're all planning for wave 2, is knowing whether or not we're going to have true assessment centers in our communities so that patients who screen positive for symptoms can be brought into those community sites as opposed to into our primary care offices. One of the things that I think keeps up a number of us in leadership is shutting down primary care because of COVID positive patients coming in. We still need to see, as we'll hear from Jonathan, our diabetics. We still definitely need to see our well babies and our pregnant patients, and it's very hard to separate these patients who may be at high risk, they may be at high risk for COVID, suspect COVID, just bringing them into the office and then them being positive, is going to be a big issue. I think my big concern is actually the safety of all of us, thousands of family doctors doing COVID tests in our office, the transportation of those swabs. And so I think we'll see an announcement soon that will make it easier for all of us to do a bit of planning. I wish that I had an announcement today, but I think we can hopefully plan to not have to swab these patients in the office. And then I just updated, somebody asked a question about PPE. And so I just reposted the guidance around PPE, depending on if people are if they're suspect patients, not suspect patients, and then patients who, if you're doing an aerosolized generating procedure.
Thanks, David. Alan, a couple of people have also asked, Victoria Chen actually posted this question, what about Cpap? So you talked about nebulizers and spirometry. What about Cpap?
Well, Cpap is a positive pressure ventilation, as you know, so there's going to be some degree of aerosol produced with that. When we use Cpap in the hospital, we have a negative pressure room. So I think at home, you have to decide where you are and who's around. It's going to send particles a little bit into the air. If you're being quarantined for COVID exposure and so on, I think it will be very smart of you to make sure you're in a different room and with a good distance away from the Cpap machine. I think the dangers of untreated Cpap for the individual person are higher than treating it. So you should be using your Cpap, but in a way to try to protect the rest of your family. So slightly aerosol generating, nothing like a nebulizer though.
Thanks, Alan. So my colleague Bill Watson has asked, how often do we see patients with typical COVID symptoms that are negative for COVID? So he's asking, I guess, about false negatives. So I think this relates to your previous discussion, Alan. We have someone with symptoms, we may think they have a high probability, maybe think they have a low probability, we tell them to go get tested, it comes back negative. How much can we rely on that and let that sway what we do next? It's
a hard question because there's a lot of factors. The first factor is how well the swab is done. it has to be done proper nasopharyngeal swab. And if you just stick it in a little bit and don't leave it in long enough, you might miss a virus from that point of view, depending on the viral load. We also know that it depends on the timing of the swab. And early on in the illness, the viral capture is higher. Later on in the illness, the capture may be lower. And we're not yet there with serology. So I think it's probably safer if you think it's COVID to assume it's COVID if they've had a proper viral prodrome in a high-risk situation. Just assume that way and quarantine appropriately and follow up. And anyone who is positive, by the way, needs fairly careful follow-up because you know that there's a delayed issue here. You get, you have a viral illness initially, but then you can crash into shortness of breath and needing respiratory failure that can happen anywhere from 4 to 14 days later. So if you are managing someone virtually with COVID, they need to be checked in on pretty well on a daily basis to make sure they're not getting more short of breath. But the answer Bill's question, you're either thinking it's positive and treating them that way based on your supposition, based on risk, or their swab. There's a lot of people out there who have question mark COVID, and I think we're going to have a whole other explosion of patients who were COVID positive, who have a lot of post-COVID symptoms. You're hearing a lot about long haulers now and people who had illness and recovering. And we already have a whole group of people with chronic fatigue syndrome and chronic pain syndromes related to unknown factors. Some of these people are going to be post-COVID, and that's going to be very real. But I have to be also concerned about the ones who never really proven to have COVID, who are also going to have these symptoms that we're going to have to figure out in our practices as well with disability claims and so on, which is going to be complicated. So Bill, I think you want to prove it and you want to clinically think whether your risk is high or not.
Thanks, Alan. So I'm going to throw out one last question to you, and then there's one remaining probably in the chat that I'll ask you to answer afterwards. Sure. But the question the last question I'll ask is, somebody asked, how do you advise clients about COVID airborne risk indoors?
Well, we know that the risk indoors is much higher than the risk outdoors because of how the air flows and because it lives on surfaces and so on for a long time. So I think that's why masks indoors has been the new recommendation for most areas, just to try to prevent transfer of the illness. So I think it's a real thing. I'm not sure what the question's coming from. Is it a higher risk indoors than outdoors? The answer is yes. Should we be more careful indoors than outdoors? Yes. So that's why I say if people are going to use a peak flow meter, for instance, which is something where you blow into a thing to see what your lung function's like, you don't do that in a closed room. You do that maybe out on a balcony where you're dispersing that volume into a big, huge area rather than into a house. And anything you can do to decrease that risk is probably appropriate. So I think, yes, indoors, you have to be a little more careful than outdoors. And that's why the outdoor social distancing is a little bit more relaxed compared to indoor.
Yeah, thanks,
Hope
Alan. So there's one remaining question on the Q&A that I might ask you if you could just type that answer in. And I'm going to turn it over now to Jonathan Bertram, and we're going to just sort of shift gears for a little bit, because I know, Jonathan, you're a lot of the work that you do really focuses on chronic pain and addictions, and that's a whole other category of people that we've been worried about during COVID and have had to sometimes change what it is that we do. And so maybe you could just speak from your perspective as a practitioner and someone who's also supporting other clinicians and communities, how you've changed, what we've had to change in terms of supporting people with COVID. And I think, Brian, we probably don't need any slides yet, and we'll put the slides up when we're ready.
Thanks, Tara. The sort of two populations that I've both tried to anchor my practice with some common principles, but then also respect the differences, are people with addictions, specifically opiate use disorder, although that's not the exclusive addictions problem during COVID, and people with pain, chronic pain, and almost kind of two subgroups, individuals who have chronic pain. The pain itself is not always stable, but their response to treatment is fairly adherent, fairly consistent. And then people with chronic pain who may have a mixed opiate misuse or addictions picture. And in those cases, obviously their pain can be quite unstable, but the means by which they try to manage their pain, how they report their pain, and subsequently how they use their opiates can be unstable. And those are really difficult situations to manage generally. but with COVID, there's a real sort of balancing of risks. Obviously, there's the clinical risks that are related to a person's pain, their addiction, their opiate use, obviously their mental health as well, but also the risks related to not receiving care in a way that can result in opiate overdose. One of the sort of underlying narratives to COVID in the pain and addiction circles, and especially the addiction circles, are the sort of reemergence of opiate-related overdoses, and how that in many ways is the pandemic that's been pushed to the background and is coming to the foreground for the most tragic of reasons. And so thinking about, all right, if I'm going to see this person to provide them the best care, provide them the best safety, not just with relation to making sure that their access to opiates is as safe and as reasonable as possible, but also to make sure that because there are higher barriers to care now because of COVID, that they're still receiving, similar to what Alan mentioned around just the care of their condition. They're receiving the appropriate care of their condition. Really beginning to dissect the risks of things that we really took for granted before. If they have to come to clinic, if I have to see them, what's the risk there? If they're getting into a taxi or an Uber or taking public transport, what is the risk there? And if clinical assessment isn't so much where I'm pivoting to, but I know for many of my colleagues, the concern is around access to opiates, and if that has changed, whether that's greater access to opiates or they're not doing as well, so having to apply the same restrictions to access. What is the risk of coming to see me in clinic versus coming just for their urine drug screen, and even dissecting, if they're having to sit and wait, what is that risk? And then extending it over to the pharmacy. So I often, when I started sort of seeing people in March and was trying to reconcile a lot of these pieces, was diving into things that I probably wasn't nearly as much before. How long are you waiting at the pharmacy? How do you get here? And not that I didn't know that before, but really like who's on the bus or on the TTC, and then really thinking about who I'm bringing in, how many people I'm bringing in, and especially because in Bowmanville I run a solo practice, but share a waiting room with a lot of my family physician colleagues, and here at CAMH obviously share a waiting room with a lot of my colleagues at Compass at the addiction service. Really trying to reconcile, okay, how many in-person appointments are we having and when, and really thinking about who's coming in the morning and the afternoon. So both so that objectively I can think about risks as objectively as you can, I guess. And also for the person who I'm asking to come in, trying to reconcile their own anxiety about coming in, which is of course a far more relevant issue for an individual with pain addictions or mental health. Their hesitation and in many cases insistence that they not come in, whether or not that's something that I can help alleviate by talking to them about how I've dissected risk. And I have to take into account the encounter, the conversation. When they're at their most anxious, they're probably not as willing to get into a dissection of risk with me. So having to divide out encounters, probably doing more encounters than I normally would. And in some cases, that's not specifically for medication management. In some cases, especially for the sake of them having some predictability around their own medication, maybe I'm seeing them every 2 weeks, but I'm extending their medication for 28 days. And then the every 2 weeks, sort of the staggered intermittent appointments are really counseling, reassessment of their clinical situation, but also a lot of communication around what our framework can be. And that's different for different people. There is a Medify document that I'll sort of ask Brian not to show now, but at the end of my little monologue here. There's a Medify document that sort of illustrates principles that are important for the prescription of opiate agonist treatment, and I actually used some of the principles with this Medify. It's a Medify CAMH OMA joint COVID-19 document, and I use these principles in thinking about methadone and the risk there to kind of anchor myself when thinking about just opiates for chronic pain in the setting of addiction. And for that matter, just in the setting of maybe instability with the use of opiates. And my thoughts in doing that were really, okay, well, we know methadone has a particular risk. There's a sort of roughly 72-hour, but probably longer sort of steady state piece, especially when talking about the changes in dose, but also if a person is possibly, if their physiology is changing, either because of other substances that they are using at that time, or simply a change in their metabolism, not really knowing how they are doing just at the point of encounter. And if those risks are there, and if that document, it really speaks to this idea of expanding a person's number of carries, even if they weren't, previously receiving that many carries, because we are trying to sort of walk that very delicate line between their COVID risk and their risk with opiates. And there's a good JAMA article that's out, and Mina, my apologies for not sending you the link, and I will sort of scurry to do that before the end of the webinar, if not afterwards. There's a good JAMA article that kind of just speaks to, that came out in May, I think, that kind of speaks to thinking about those COVID risks with opiate users, whether that's a person with pain or addiction, thinking about CNS depression, and obviously how a person from a respiratory standpoint, and I'll be careful to not venture into things that I think Alan's better suited to discuss, but from a respiratory depression standpoint, run a higher risk from a COVID-19 under COVID-19 circumstances. So those are really the things that we talk about. Ultimately, though, it is I think for me, my most important outcomes are the same as what they were before COVID. It's making sure a person is stable in their own clinical assessment, and stable in the setting of their access to opiates. In most cases with that document, and especially for methadone, less so for buprenorphine, because of the respiratory depression safety profile that is much higher with buprenorphine, are a lot more liberal with carries for methadone than what you see in the regular CPSO guidelines. And there is a framework. So while we've really sort of messaged this idea of people being able to actively and more freely receive carries, we've created a really sort of step-by-step framework. It is, kind of quasi-formulaic, if you will, to try and help people sort of work off of a ladder when it comes to increasing the number of carries. So that's kind of I guess an overview of the approach and the differing but also similar approaches with pain versus opiate use disorder management.
Thanks, Jonathan. I wonder, Brian, if you're able to just put up those Medify slides, the Medify provider tools. For those of you who aren't familiar with Medify, it is actually a wonderful resource hub to support physicians and for managing addiction and opioid use. So they have a number of different provider tools, and they do have some COVID-specific provider tools. And the specific one Jonathan was referencing, called Opioid Agonist Treatment Guidelines, is among those. If you go to the next slide, Brian, the next slide does have the guidance itself that you're talking about, Jonathan. And I think Mina put that out onto the chat. Is there anything else you wanted to say about this document, Jonathan?
Yeah, so with this particular document, I'd encourage you. I'd encourage everyone, whether you're an opiate agonist treatment provider or a chronic pain provider, to really look at the guiding principles, the idea of what the purpose of carries are, and a little bit further down in the page, what the purpose of urine drug screens are. These are two areas that are very subjectively driven in terms of history reporting. Obviously, there's an added dimension of objective assessment when it comes to physical examination, and that's certainly an important piece when we talk about chronic pain, especially in the setting of central sensitization, mixed nociceptive versus nociplastic presentations. And neuropathic. For those of you who aren't familiar with the term nociplastic, it's this idea of a person having an injury, but the efferent signals from the brain are amplified relative to the afferent signals from the injury going back to your central nervous system. So this idea of being able to objectively assess is reconciled against obviously what kind of COVID-19 respiratory risks we're exposing the person to, but also, what kind of anxiety we're also exposing that individual to. And I did see, not to sort of preemptively jump onto the chat here, but I did see that there was a question about virtual visits and the utility of those versus,
Yeah, so Rosemary Law asks, are you finding that the virtual visit is less effective for this population at risk compared to an office visit? I mean, I'll say even from my own practice and experience, I think sometimes for people with opioid use disorder, sometimes the visit with me is it's kind of like a stabilized, it's the one visit they have that go out to see someone different. Yeah, what's your thoughts and approach there, Jonathan?
Yeah, what's interesting is thinking about the visit has really forced me to sort of think about the visit in terms of its context within care. And I think that the visit has to be used differently. I kind of spoke very briefly to frequency of visits and how you stagger visits. The nature of the visits now become more blended as opposed to kind of doing a follow-up versus sort of a more overall comprehensive assessment. And so you may actually connect with them more often than you did previously. And also it ends up having an influence on your plan. One visit will simply be a counseling visit, whereas another will directly affect sort of tangible steps that you take with plan. So I think absolutely the visit becomes different. But the way to deliver effective treatment in being different can still sort of realize the same outcomes. Is it going to provide us or allow us the sort of same certainty and confidence? No, because these are different circumstances. These are conditions that we're continuing to adjust to. And even, how I weigh COVID-19 risks are different. Not that Bowmanville is terribly far away from Toronto, but Durham even, and certainly Durham as you start to get out a little further east, and especially when I think about patients that I have in Coburg and out in the Kawarthas, they're dealing with different regional risks from the people who are obviously west of Bowmanville and the people I see at CAMH. And so my reconciliation becomes very different in terms of whether we're talking about, we were talking about this on Tuesday when we were preparing for today's session, what's that, how do you reconcile more frequent dispensing if you can't do urine drug screens in order to ensure that a person, either isn't overusing or isn't supplementing? And is it reasonable to say, okay, well, I'll complement with more frequent dispensing in order to sort of adjust for those issues around not being able to do urine drug screens as often? And I would say you're right. There's a difference there, but it's also a difference from region to region. So the person I see in Coburg or the person in Lindsay is dealing with the different risks and going to the pharmacy more often than the person that I'm seeing in Toronto.
Thanks, Jonathan. Alan, I think you wanted to pipe in there.
Well, I was just going to say that, so I got dogs in the background, but I was just going to say that, chronic pain patients and people with substance disorders are a little bit different in the frequency we have to do urines. But don't forget that we have to periodically do urines on people who have chronic pain as well, just to make sure they haven't drifted from one condition into another. And that's one of the difficulties in doing virtual visits for our pain patients is how often do you have to see them, just if nothing else, do the urines. And I've yet to figure out a method of doing urines remotely that I can trust. So sometimes I'm having to see people just to make sure their urines are clean, whether it's going to be opiate use disorder or actually just for chronic pain. Otherwise, I think patients are really actually very happy to be talking about stuff. And most of the stuff we do for recurrent visits for chronic pain are the conversation, the story, their mood, and then using tools like a BPI and a depression screener for that population may be very useful in terms of following them up. So I think we can do just as about everything we can do with a regular visit, with a virtual visit, with the exception of perhaps the urine. Sorry about the dogs.
Thanks, Alan. No worries. So I'm going to change gears a little bit as well, because we got about, 15 minutes left, and I hope to also share with you, some thoughts that myself and some colleagues have pulled together on managing diabetes during COVID-19. We know that diabetes is, one of the most common chronic conditions that we manage in primary care, and our approach to it, though, is going to have to change. So many of us, might have deferred care for the first 3 or 4 months, and we know we can't continue to defer that care indefinitely. And so what we really need is almost like a new approach to how can we continue to deliver the effective interventions, ensure people are getting evidence-based care, but at the same time, maybe think about doing that in a different way that lowers people's risk and the risks that Alan and Jonathan have spoken about of coming in to the clinic itself and traveling there exposes people potentially to COVID. So, together with the Center for Effective Practice in Diabetes Canada, us at the department, we've pulled together this guidance that's available on the Center for Effective Practice website now. And it really speaks to sort of thinking about how we might want to rethink, what is it that we need to continue, but what is it that we are able to stop, and what are some of the things that we might be able to do differently. And so when it comes to what we should continue, when we think about diabetes care, we are still going to have to see some people in person, and how often we see them in person is going to depend on their disease severity and their access to virtual technology. It's also obviously going to depend on the safety of the environment based on COVID risk. And so, we do need to continue to see people in person when that's needed. But, and when people have poor risk factor control, we do need to continue to test. And I think Alan made the point that we want to make sure that people's condition is well controlled. We know people with diabetes are at higher risk for severe COVID illness, and we want to be able to have their glycemic, their blood pressure, their blood sugar, cholesterol, et cetera, as controlled as possible. And I guess the other piece is that we always have known that self-management is important, and probably this is a time for us to strengthen it even further. But there are also some things now that we might be able to safely defer, delay, and when we think about that, if people have been stable on have an A1C that's close to what their target should be, do we really need to do the A1C every 3 to 6 months? Can we prolong that time period? We think we probably can. We can probably defer screening ECGs. We can actually even defer retinopathy screening to a 3-year interval, according to evidence, for those with no previous eye disease and an A1C less than 8%. When we're thinking about starting a medication that is for primary prevention, we can consider delaying that in order to cluster blood work. So just to this point is that, we want to minimize visits not just to ourselves, but visits to pharmacies and visits to labs. And one way of minimizing visits to labs is by clustering our blood work and just being much more intentional about that. And then when it comes to doing things differently, I think this is where we may even consider doing, doing less frequent screening of cholesterol, especially if people are on a stable dose of a statin, their LDL is on good target, and medication, their adherence is good. I'm actually going to take it to the next slide, Brian, and give you a visual of kind of a a new schedule that might have put into context what it is, some of what we're talking about, and the shift. And when I think about the shift of what it is that we might want to do, we were used to seeing our patients with diabetes every 3 to 6 months, and we were used to seeing them in person during that time. And now we think that most of the visits probably can occur virtually, still at that every 3 to 6 month interval. And we can still continue to use, the A, B, C, D, E, S, 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 S as our guide into how we do those visits. But we can, how we do them virtually is going to be a little different, obviously, than what we do in person. And I think there's a couple of things that just to highlight. One is I think there's a much bigger role for patients in self-assessment. So working with patients to help them to do, for example, their own blood pressures at home where they're able to. Now, this is not going to be possible for everyone, but when they're able to, the hypertension, what we include in our guidance is that Hypertension Canada has some fantastic resources actually for both patients and physicians to guide them what blood pressure monitor you'd be able to buy, how you can do your blood pressure at home. And then we've also provided some guidance. We know that blood pressure measurement at home is going to be on average lower than in the office. And so how can we adjust or our own targets when we're trying to interpret what our patients are telling us about their blood pressure? The other thing we often think about doing only in person is foot screening. And in our tool, we provide some links to a UK tool called Touch the Toes, or the Ipswich Touch Test, which patients can do together with their caregiver at home to screen for neuropathy. So this is something, again, if they can self-assess at home, it makes it less needed for you to come in. Of course, patients can also send you photos, or you can use video to assess their feet. So that's one really key way in which I think management of diabetes in this COVID time can be different, is getting patients to self-assess more at home. Of course, self-management is the other piece that's really key. And in our document, we talk a little bit about some potential apps that you might be able to share with patients. I'll be honest, when we did the review of the apps, unfortunately, a lot of them weren't, we thought, of like a high quality. A lot of them focused on glycemic control. A lot of them had areas where you needed to pay for upgrades in order to share, for example, what you find with your primary care provider. But we've named a couple that are quite popular, and we've also provided some thoughts around considerations there. A lot of the glucometers themselves come with apps. But in addition to apps, it's important not to let go of things like diabetes education, and we've included a number on the tool. And Brian, I wonder if you could actually go to the actual tool PDF for a moment, and because this might be easier for people to see visually. But there is free diabetes education provided by Diabetes Canada that people can access through a 1-800 number, and we've listed that number in the tool. So with the virtual visit, I think most parameters can be addressed. So if we continue, so this is the self-management number 1-800 Banting that we suggest. Brian, if you can scroll back up to the schedule there. So most things can be managed through virtual visits. Brian, can you scroll back up to the image of the schedule that we were on, just on the first page? Thank you. So most things can be managed through virtual visit for most people, but not all people. But we do think probably an annual visit is going to be needed. So if you can go back to that schedule image, Brian, that would be great. I know it's a little hard to find. So in person, what is it that we should be doing? So when you come in person, those visits probably should be really short. When possible, we should try and do a pre-visit questionnaire, and there's a great one by Ocean again that you can use that we link to. When you come in, that's when, if patients haven't been able to do a foot exam on their own, this is a great time for us to do that. A great time for us to calibrate their blood pressure machine. And of course, the in-person visit is a great time for us to give shots and immunizations, which continue to still be really important. if we're not, checking A1C as frequently, I think addressing medication adherence becomes even more important. We may want to use smart blood glucose self-monitoring as a proxy as we delay A1C or visits to the lab. So these are all considerations that we can take into account. And then we've kind of put a schedule together for lab testing and referrals that we think may be appropriate during the COVID time. So this is just a bit of an overview of the, the guidance that we've put together. Brian, if we can go back to the slide, I think I just have one last slide that I'll show up. And this is really, I think the slide that I want to show is really trying to highlight how we balance in-person or virtual visits. And I think I just credit some of my colleagues, Onel Bhattacharya and Green Lunan, to just sort of think about this sort of 2x2 framework where we can think about disease severity from low to high and capacity for virtual self-management, including like health literacy and virtual technology from low to high. And we can see that, if you've got low disease severity and high capacity for virtual self-management, a lot of the care can be developed for chronic conditions virtually. But on the other hand, if we've got a low capacity for virtual self-management together with high disease severity, we're going to need more regular in-person visits. And something that I've been thinking about a little bit more is, how can we actually increase people's capacity for virtual self-management? So for some patients, that might mean, us donating a phone, for example. And I know our own practice has been trying to do that. Others have raised this issue as, it's pretty unfair that some people can afford a blood pressure cuff to do their blood pressure at home and others may not. So I think as providers of study, we need to think about how we can kind of close this digital health gap. And of course, all of it kind of is in interplay with the amount of COVID that's in the community, as Jonathan mentioned. So when you're practicing in Toronto, it is different than if you're practicing in a community with no COVID. I noticed that there are a couple of questions for us on the Q&A. One person asked, is K030 billable through any virtual visit platform or only OTN invite? And so my understanding, and David, you can correct me if I'm wrong, I think K030 is billable for OTN, but not with the virtual care codes that have been introduced for telephone visits.
Correct.
And then there's also another question about have you started ordering COVID antibody tests? And I don't know if anybody of my panelists wants to try and answer that.
To the best of my knowledge, there's no yet accepted serology yet for COVID that's reliable. And even if we have serology, one of the concerns is how long the immunity lasts for of having an illness. It's one of the great questions that's going on about this is having the infection, does that mean you're not going to get it again in the future? So I don't think we're there yet for having a blood test to see if you have an IgM, which would be an acute phase reactant, or IgG, which means a long-term immunity. Even if you have those, is that actually going to be sustainable over time, or is it something that's going to wear off? So the answer right now is we don't know. It's too early. Sorry.
I think Alan Grill asked, do we think, that will mean that the billing changes will actually cause people to bring people in more frequently than in the scheduled visit? And I think that is very possible, Alan. So, I think this is where we need to work with policymakers to try and adjust kind of our incentives associated with the finances. Apologies that I haven't been keeping up with the wonderful chat that's going on here as I was speaking. I think Jennifer Young, you had a comment about a home sat monitor, and I wonder if you wanted to speak to that.
Really just what I said. I have a couple of COPD patients who are low income and they bought their own home sat monitor and have found it to be a really useful tool. They are less than $100, and at any rate, I would say we shouldn't assume that low income people would not want to invest in something like that.
Thanks. So, this has been a fantastic discussion with, I think we've covered a lot of topics. We are going to be posting all of the resources as well as the recorded webinar on our website. And Brian, I wonder if you can bring up our last slide. So we'll be posting our resources on our website, as well as the webinar recording. We are scheduled for our next community of practice on August 21st. So we've decreased the frequency over the summer months. And I think, we're going to probably building on this kind of conversation, because some people have been asking, what do we do? How do we prepare for fall coughs and colds? And there hopefully will be more guidance and plans for how we can, as a community, respond to that, as David Kaplan alluded. So our hope is that in August, we'll be able to come together and discuss that more fully. And this, discussion about chronic conditions, this was just the beginning. I think there's so much that we could be discussing, but I just wanted to thank Jonathan Bertram and Alan Kaplan for their time today, and for illuminating the areas of chronic pain, addiction, and COPD and asthma control. All of the resources are available online, will be available online for people to take a look at afterwards as well. And thank you again to our special guests, Jennifer Young and David Kaplan. Just a reminder that the session is accredited for 1 main pro credit, and you will be emailed that certificate in a couple of weeks. We will also be following up with an email with some of the resources from today's session. So thank you very much to all.